So what I'd like to do is start, you have a table in your book, and what I've done just to make this a little easier is we're just going to follow the table straight down, starting with the first parasite and just moving down that table, okay? So the first organism we're going to talk about is Entamoeba. And Entamoeba is I'm not going to say super high yield, but you don't want to forget it. So we'll put it in the mid-range as far as high yield. We don't want to call it low yield, but it's not super high like some of the other stuff that I'm going to talk about. Entamoeba histolytica is the causative agent of amoebic dysentery. Now we talked about 2 bacterial agents of dysentery. See if you can think about what those are. We talked about enteroinvasive E. coli, and we talked about Shigella dysenteriae. And this is amoebic dysentery. Now, one of the things I want to show you might be on a pathology type report from a patient with Entamoeba. You get these flask-shaped lesions, all right, from Entamoeba histolytica, and you can get extension into other organs, like the liver, for example. When you get extension into the liver, this is a very severe complication from Entamoeba. And one of the things you can also see with an Entamoeba infection is pseudoappendicitis. So you can also get a pseudoappendicitis-like disease, like we talked about with another bacteria. So try to think about what that is. That was Yersinia enterocolitica. All right? Now, it's dysentery. It's invasive. We're going to get blood and pus in the stools, like we talked about for invasive diarrhea. Okay? What form is transmitted? Okay? You acquire Entamoeba histolytica by fecal-oral contamination. And you're typically ingesting the cyst form of the organism, okay, by fecal-oral transmission on contaminated fruits and vegetables or contaminated water, for example. How are you going to diagnose Entamoeba? You're going to look for the trophozoites or the cysts in the stool. And they're actually fairly easy to pick up because the nuclei have a very sharp central karyosome and little chromatin spikes. And sometimes you can actually identify red cells inside of the organism. So that tends to be very diagnostic for Entamoeba. The treatment for Entamoeba histolytica is metronidazole followed by iodoquinol, all right? And we do see infections from Entamoeba in the U.S., but not as commonly as you're going to see Entamoeba infections in developing countries. So we do see this in the U.S. It's probably not one of the leading types of parasitic infections, though, that we do see in the United States. All right, so we're going to move down the list. We're going to talk about Giardia, which in the United States is the most prevalent enteric parasite. You can almost probably write the vignette yourself. You've got individuals that go camping and hiking, and they drink untreated stream water. They then develop a malodorous diarrhea with a lot of fat in the stool, so there's steatorrhea. And the reason is because Giardia causes malabsorption. So I'm telling you, you have a foul-smelling diarrhea, and you're all sitting at home going, is she kidding? Foul-smelling diarrhea? Like that sets it apart from anything? So let me try to explain. I'm going to give you that. Yeah, diarrhea, you probably can't find any of it that smells good. But this is just like, bam, it's like a notch above foul smelling. Why? Because in addition to the normal stench that you're going to have, you have malabsorption. So your intake of food is simply rotting in your gut. So when you alleviate yourself, when it comes out, it's going to be really, really foul smelling. So that's why they even mention that here, because of the malabsorption. Now, this is a relatively poor picture of Giardia, but you know, students tell us all the time the images aren't very good on the board. So if you see an image like that, at least you should be able to identify it as Giardia. The image, though, here is what I would consider a very good picture of Giardia. you have to be ready for an image of Giardia. You know they're going to ask you about it, and it's very ripe for the picking for them to show you a picture. Now, I actually think Giardia is kind of cute. If you look at this guy here, look, he's got 2 eyes, he's got a mouth, and he permed his hair, and he's smiling for the picture. Now, you don't get much cuter than that for an agent that causes malodorous diarrhea, okay? So how are you going to acquire this? Again, fecal-oral transmission is key. And in the vignette, they're going to mention that untreated stream water, somebody with a history, a recent history of camping or hiking and drinking that untreated stream water. We're going to diagnose it by finding these organisms in the stool. And you can see if you get a good image, good microscopy, it is very easy to detect. And you're going to treat Giardia with metronidazole. All right, so Giardia is going to be one of those high-yield parasites that you're very likely to see on the boards. In addition to understanding the clinical symptoms, you also want to be able to recognize the image. All right, the next pathogen in our table here is Cryptosporidium. And Cryptosporidium shows up as a persistent, watery diarrhea in AIDS patients, okay? And it's very, very common in AIDS patients, very difficult to treat. So we have transient diarrhea, usually in immune-compromised or AIDS patients, and the transmission is cysts from undercooked meat and then contaminated water. This is an example of a cyst. Now, this is an acid-fast staining, okay, of a cyst, but Cryptosporidium are actually acid-fast. The cysts are actually acid-fast, so that's one of the things that they're probably going to mention. So, diagnosis, you have a 32-year-old patient who is HIV positive that comes to the clinic complaining of persistent watery diarrhea. You do a stool sample. You find acid-fast oocysts in the stool. Okay? In that case, it's likely Cryptosporidium. All right? It's not the only thing it can be, and I'm going to tell you some other things that it might be, but Cryptosporidium is probably the most common. Okay. As far as treatment, in a healthy patient, it's usually self-limiting. In immune-compromised patients, though, this is very difficult to eradicate, very difficult to treat. Okay? Now, we've talked about Cryptosporidium. Cyclospora bellii is another parasitic agent that causes persistent watery diarrhea in AIDS patients. Again, fecal-oral transmission. Again, acid-fast oocysts. All right, so now, don't panic. Now we have to be able to differentiate between Cryptosporidium and Cyclospora. First thing I'm going to tell you, and I don't think they would go here, but if you have to differentiate based on the description or an image of the oocyst, Cryptosporidium has nice round oocysts. So you're going to have an acid-fast, round oocyst. Whereas Cyclospora, the cysts are elliptical. So you're basically going to have an elliptical shape. It's fairly large, but it's also acid-fast. So the oocysts look different, even though they're both acid-fast. Okay? The other thing to think about is, in addition to just having this persistent diarrhea, Cyclospora actually causes malabsorption similar to Giardia. So you can actually get a steatorrhea with Cyclospora as well. So clinically, if they're describing that and they don't tell you, anything about the shape of the oocyst, then you might start to think about Cyclospora. Now, what I typically tell my students is, if they get that question about the persistent diarrhea in an AIDS patient, all right, their first line thinking should be of Cryptosporidium parvum, all right? Sometimes what they'll do is they'll give you that question and you'll look for Cryptosporidium and it's not on the list. And that's a good time to go ahead and choose Cyclospora. If they're both on there, there has to be a way for them to differentiate for you between Cryptosporidium and Cyclospora, all right, unless they're just asking you what's more common, in which case would be Cryptosporidium, okay? Now we're going to page through fairly quickly some of the other organisms that you can see in AIDS patients causing this kind of persistent diarrhea. One of them is Cyclospora, causing again severe diarrhea in AIDS patients. Oocysts are acid-fast, but these are spherical, all right, but not nearly as common as the first two that I talked about. So we're going to put Cyclospora, and we're going to put Microsporidia fairly low down on the list, okay? So again, we've got acid-fast, persistent diarrhea, but these, in addition to staining acid-fast, also stain gram-positive, okay? So Cryptosporidium and Cyclospora, those are your first two that you want to think about, and then Cyclospora and Microsporidia kind of down there at the bottom. All right, so those two are pretty low yield for step one. Trichomonas vaginalis is actually really high yield for the boards. It's going to be one of the things that you're going to have on your differential for sexually transmitted disease. Trichomonas, and we've talked about this a little bit before when we were comparing it between bacterial vaginosis. You're going to get a discharge, but in this case it's going to be a frothy yellow-green discharge. That's different from bacterial vaginosis where you have a thin grayish discharge, but again it's malodorous, okay? And it's always described as a fish-like odor. So that's going to be one of the big clues. In addition, with Trichomonas, you have a lot of inflammation that you can see here. So sometimes this is called strawberry vagina because of all of the erythema associated with that particular infection. Now, how is it transmitted? It's transmitted sexual, but what should scare you is this third bullet point, fomites. What's a fomite? It's an inanimate object, not person to person. So if you share a towel with somebody that has Trichomonas, you can get Trichomonas. So in that particular instance, you have to be pretty careful. Diagnosis are motile trophozoites, and here's an image of one. She's got this nice big nucleus, and again, she's got a little hairdo. Those are the flagella, okay? If they show you an image of that, you're expected to know what that is, or if they mention motile trophozoites in a wet mount, okay? In old school, when doctors used to have microscopes in their office, they used to suspect Trichomonas. They would just do a little swab, and they would bring it to their microscope, and you'd actually see these little guys kind of swimming all around underneath the microscope. So it's fairly easy to diagnose, but you have to recognize the image and or the description, motile trophozoites, okay? The treatment for Trichomonas is metronidazole. That's going to be the drug of choice for Trichomonas.